Thank you. Good morning, everyone. Uh, if it was 5 years back, we wouldn't be having this panel because lung carcinoid was kind of not such a great thing as far as lung malignancies were concerned. But with the increasing use of imaging and early detection and high incidence of distant metastasis, we are now re-looking at lung carcinoid from the treatment point of view beyond surgery. That's why maybe this panel can throw some light on what can be the available strategies. So typically, as we know, these represent 1 to 2% of lung tumors overall, and almost 5 to 15% of the typical carcinoids have lymph node metastasis, with 3% having distant metastasis. They have a very strong 10-year disease-specific survival, both the typical as well as atypical carcinoids, with the atypicals faring a little worse as compared to the typical carcinoids. As far as the recommendations go, the recommendations are very sketchy across all the guidelines, where there is no definite role given for imaging, or as far as the treatment goes, apart from the surgical guidelines, there are no specific guidelines for carcinoids which have been established in literature. Coming to imaging, DOTA-NOC PET-CT or somatostatin receptor imaging has emerged as a very strong tool for characterization of these lesions. Moreover, mainly because of these somatostatin receptor imaging agents, the carcinoids have kind of shown, or they have established heterogeneity in their presence. As you can see in this case, on the left, you can see a typical carcinoid, which is showing good uptake pointed by the arrow. Whereas on the right side, you are seeing a carcinoid on a gallium dotatate scan with no uptake. Whereas in the lowermost panel, you see an avid lesion on FDG PET. So this is the kind of inherent heterogeneity that is demonstrated by these tumors. So moving ahead with our panel. So this is the typical pathological staging that we will come to when we are discussing the cases. So we'll start with the case of a 46-year-old male, a BD smoker who initially presented in August 2019 with breathlessness since 2 months and cough with whitish expectoration. On FOB, there was a growth in the left main bronchus with extrinsic compression, and biopsy was typical carcinoid. The dotatate scan was done, and I would request Dr. Indraja, one of the panelists, to read what she can see on this scan.
This is a dotatate scan where we can see intense uptake in the lung parenchyma. So can we see cross-sectional images? Yeah, there is a active consolidation, and there is a large soft tissue mass which is seen in the left hemithoracic region with increased DOTA uptakes, and biopsy was a typical carcinoid.
Yeah. So basically, on this is a dotatate scan which has kind of physiological uptake in the pituitary, in the liver, spleen, and the kidneys, as you can see here. And this is the lesion which is concentrating, which is basically having high somatostatin receptor expression, and as a result, we can see the uptake. Now, I'll ask Dr. Devyani what would be her take as far as when the patient presents to her in the OPD, what would be her advice as far as a surgeon is concerned?
So, given the patient profile and the fact that the biopsy is a typical carcinoid, it makes every surgeon think that let's do everything that we can possibly do to try and get it out, because surgery is the mainstay of treatment in a typical carcinoid. But unfortunately, in this case, you can see the tumor actually going across the arch aorta onto the contralateral hemithorax and completely involving the subcarinal area, including the left main bronchus. So even with something as drastic as a pneumonectomy, it's going to be difficult to get an R0 resection on this. So unfortunately, this is one of the rare cases where, despite being a typical carcinoid, I would not think surgery would be for this guy.
Yeah, thanks. So point taken. So now just coming back to the pathologist, now we are seeing a typical carcinoid. However, as far as the imaging is concerned, we are seeing areas of necrosis. Imaging features are not a very classical depiction of a typical carcinoid. So anything additional that you normally do in these case patients where the imaging really doesn't match with or you have a CT with you when you are interpreting the slides, a baseline CT which is showing these kind of sinister features. Anything additional that you do on histopath?
Yeah.
Actually, in this case, we have a biopsy. So the amount of tissue that we have is quite less as compared to the entire lesion. So that can cause some difficulty in classifying it as a typical or an atypical carcinoid. So in this case, first of all, we must document the number of mitosis. So since it is a typical carcinoid, I think we must not have seen any mitosis on the biopsy. But we can also do a Ki67, that is a proliferation marker. So currently there are no established cutoffs for the Ki67, but since the imaging looks aggressive, so we can do a Ki67 on this. And if it is more than 5%, it can point towards an atypical carcinoid.
Okay. So basically, apart from your Ki67, MIB index and necrosis, there is nothing more you can add as far as pathology is concerned if your imaging is not really helping you characterize the lesion. Any molecular markers, any IHC markers which you run on these, apart from the routine chromogranin and synaptophysin which you do for characterization of neuroendocrine component?
Yeah, in this case, I don't think there will be a doubt as to the subtype of the tumor, but and currently molecular studies are also not recommended in carcinoids because there are no targeted therapies as such.
Yeah.
But in pancreatic carcinoids, there is a marker ATRX.
Yeah. So I was actually coming to that. So anything that you extrapolate from the JEP nets that you can apply to lung carcinoids, any literature that is available with regards to?
So in pancreatic carcinoids, we use Ki67 as an established criteria for grading of grade 1, 2, and 3. And but that is not established in pulmonary carcinoids because there are no well-powered studies which have established a cutoff, and also the method of counting mitosis is very well defined in the gastric neuroendocrine tumors, while in lung carcinoids the method has not been given. Okay,
thank you. So just once we have ruled out surgery now, so what can we offer to this patient? Dr. Indraja, can you have an option with you by which you can treat this patient or reduce the disease burden to make it operable?
Yeah, as the DOTA uptake is there, so there is a high SSTR expression and high SSTR load. So we can give a PRRT. PRRT is a peptide receptor radioligand therapy. It's a systemic targeted therapy so that we can use CM octreotide, which is labeled with lutetium-177. That is an established treatment for JEPNETs. So same thing we can extrapolate for lung carcinoid to make as a neoadjuvant treatment so that we can reduce the size of the tumor by using anti-proliferative agent of octreotide. And then we can see, give a 2 cycle and then assess the response by same gallium dotatate. And if we can make it operable, then surgery, we can treat it with a curative intent.
Ajay, would you like to propose anything from medical oncology, considering that in gastroenteropancreatic tumors, we use octreotide as the first line treatment, and then PRRT is often considered as second line. So anything similar in lung carcinoids?
Again, sir, in lung carcinoid, here in this case, where disease upfront is unresectable, there is no much data in typical carcinoid to give as some anesthetic treatment. So preferably, if unresectable we prefer, and there is a good expression of SSTR, so PRRT will be preferred.
Okay. So basically, this patient did receive 4 cycles of PRRT, but after having received 4 cycles, there was no significant change in the disease burden. Basically, it was kind of stable disease. And since this was kind of a non-responder, we did an FDG PET. And as we see here, there was kind of congruent uptake seen on FDG PET as well in this patient. So I just wanted to make a comment here regarding FDG PET. This is one of the published studies from Tata Hospital by Dr. Nilendu, which has shown that nearly 10% of the typical carcinoids showed distant metastatic disease. And which is a point which has to be noted, considering that the heterogeneity does exist when we are talking about typical carcinoids as well. Of course, the SUV max was higher for atypical carcinoids as is expected. So, Dr. Indraja, where can we add FDG PET? in typical carcinoids? Is there a particular scenario where you do it, or it is always after PRRT that you look at the response and then decide to do an FDG PET?
If the biopsy is showing typical carcinoid and DOTA is showing intense uptake, then you should go ahead with the PRRT. See the response after 2 cycles or after 4 cycles. As in this case, there was a stable disease, so we did a FDG PET. So throughout the course of the treatment, at least once you should do the FDG PET to see the tumor heterogeneity. And if FDG is showing uptake, then I would like to ask pathologists to see again the biopsy changes if it is going to a transformation or like a typical carcinoid or it is dedifferentiating. So at least one you should do FDG PET. So that it can act as a roadmap for adding chemotherapy like everolimus or something.
So okay. So just my question to the pathologist, as Indraja said, would we be looking at a rebiopsy in this patient,
Yeah,
or any kind of molecular markers would you like to do?
if it's a stable disease, then maybe a rebiopsy should be done because, as I said earlier, the tiny biopsy is not representative of the entire tumor area and taking into account the tumor heterogeneity within the primary tumor also. I think we could look at a rebiopsy to see whether there are mitosis. Or
Yeah. And Dr. Devyani, is there any chance of doing a, I don't know whether this approach is really followed in thoracic surgery or for carcinoids, a cytoreductive surgery or a palliative surgery for such patients?
It's not actually. So in carcinoids, if you cannot achieve an R0 resection, you'd rather not go in at all. And especially if the patient has come back with a PS3, he's certainly not a candidate for any thoracic surgery from my side.
Correct. Ajay, any targeted therapy that you can offer now that the disease has not responded by PRRT?
Yes, sir, we can offer somatostatin analog. And again, along with the somatostatin analog, we can add some targeted drugs like everolimus or flunicine, and sometimes VEGF inhibitor bevacizumab.
Okay. Any?
Question for Ajay, actually. So we mentioned E627. So does that kind of help you take a call on whether chemo is going to work in this patient or not?
Yes, ma'am. In case Ki67 currently not, as Madam said, it is currently not recommended as in pancreatic and GI carcinoid is not currently having any strong guideline in lung. But indirectly, we are still using in lung also. Ki67 is above 5%, at least above 20%, we are very sure chemotherapy may help. And again, above 4%, again, patient is in this condition, so we may consider. But at least in upfront, we'll start some targeted therapy. If not working, and in rebiopsy, we are seeing the Ki67 index is on moderate or higher side, we may consider chemotherapy also.
Okay. And Dr. Indraja, now that we are seeing that this is not responding to beta PRRT with lutetium 177, would you consider alpha therapy for this patient?
Yeah, usually the tumor is very large. In this patient, the tumor is very large. So alpha PRRT is used for basically skeletal metastasis with the micromets if they are there, because the soft tissue penetration range of the alpha particle is very minimal. So alpha PRRT might not help. There is no literature which suggests that use of alpha PRRT in lung carcinoma. So we can think of yttrium 90, just give 1 cycle and see. Yttrium 90 has a better soft tissue penetration range.
Okay. So just to conclude this from this case is when we have something which like PRRT, which has not given us any response, I think we have to go for targeted therapy in patients which are inoperable and refractory or non-responders to PRRT. So just coming to our second case, which is a young female presented with fever and cough in November 2021. Again, a left lower lobe lesion with endobronchial extension. And that time the patient was having a provisional diagnosis of hydrated cyst. FOB, the left main bronchus was completely occluded 1 centimeter beyond the carina. She underwent left open pneumonectomy on 19th of Jan, and it was a grade 2 NET with involvement of the bronchial cartilage. So with this histology, Ajay, it is a grade 2 NET, the cartilage is involved, and now the patient has come to you. Would you like to start something upfront in a grade 2, or what is your take for this patient?
In grade 2, sir, we'll observe only. There is no any definite data for adjuvant in this case.
Okay. Now, this was the final histopath report, Dr. Nupur. It is said that it is a typical carcinoid. Necrosis is not seen. MIB index is approximately 4 to 5%. Now, you have a MIB index, as you said, of 5%, but there is no necrosis seen. And so, how will you label it as typical carcinoid with a high MIB index, or I mean, how will you interpret this histopath report?
I would still label it as a typical carcinoid only, because it definitely shows a typical morphology of a carcinoid, and there are no mitosis, because mitosis are very important in classifying carcinoids, and there is no necrosis.
Okay.
And since it is a pneumonectomy, the entire tumor must have been examined by histopath.
Okay. So this is the scan. So we all, pathologically, this patient seemed to be a typical carcinoid with a very good behaving tumor, but this is how the scan looked. It was showing extensive metastasis. Patient had liver studded with mets, entire bone marrow was involved. And this is how the DOTA-PET CT looked. We also did an FDG PET looking at the disease burden in this patient right up front. So this is how the FDG PET looked. So Dr. Indraja, in your experience, how many of the typical carcinoids have you seen which are, kind of showing this kind of disease burden or this kind of uptake pattern, distant metastasis?
Till now, we have done around 60 patients. In 60 lung carcinoid patients, we have done a DOTA. So hardly, I think, around 3 to 4 patients are presented with such heterogeneity. And,
okay. Yeah. So now, Ajay, do we have a role of combination therapy here along with PRRT? Would you like to combine something? I mean, now you are seeing that this is a very aggressive disease, which is not really going hand in hand with the pathology, but the imaging shows that it is an aggressive disease. So do you have something to offer in combination?
Yes, sir. From start, though it is a typical carcinoid, but it is known that 5 to 20% cases with typical carcinoid will have definitely bone and liver metastasis. So it is unusual for us, but it is possible. So when we are seeing such a aggressive disease and there is a fire, right now in lung carcinoid, the MIB is not the 2015 WHO classification had not incorporated MIB in these. But from GI on pancreatic carcinoid, if there is a 4 to 5% MIB index, we may consider adding chemotherapy here. And here also in TMH also, we generally give a combination of PRRT along with the captain.
Okay, so the same captain which you use for GEP NATs, you also use for lung carcinoma.
Because looking at this diagnose this picture, and we are not having a much data because of these are very rare tumors.
Right. So basically, when you have such an aggressive disease, to conclude, we have to go ahead with PRRT and combination chemotherapy, even though it is a typical carcinoid. And we are coming to our last case. We have a 52-year-old female, a dentist by profession, who presented with low backache. And there was a broad-based pleural and light lower intrathoracic lesion without any paraspinal extension. Now it had a very long vertical extent from D6 to D9 region. And at presentation, the patient had multiple liver mets. Biopsy was suggestive of a neuroendocrine tumor, Ki67 of 2%. This is the report that we have. And now this is the gallium DOTA-TET scan. Dr. Indraja, what would be your preference? Would you do an FDG PET? You would offer PRRT? I mean, how would you go about? PRRT seems to be the logical option, but will you do an FDG PET for this patient before going ahead?
No, I'll first give PRRT only.
Okay.
After 2 cycles, we'll again, as I said earlier, we'll assess with the DOTA. And if the patient is not responding or showing any atypical features or anything, then only we'll do FDG. Because literature also says that only LAR is the first line treatment. And in such extensive disease, we can add a PRRT.
Right. Okay. Ajay, octreotide in this patient, would you give?
Octreotide, sir, we may consider because the Clarinet data has shown that it has a benefit in terms of preventing the progression.
Right.
So if we can add octreotide, but beyond that, nothing else systemic therapy will be needed.
Okay. So if we are giving PRRT, would you still add octreotide or
If not symptomatic, sir, we can avoid.
okay. So now there was also a thought process of adding chemotherapy. However, somehow the medical oncologist asked for ATRX, and immunohistochemistry for ATRX is retained in the tumor cells. That's why CAPTEM was not added, considering the behavior. So how do we make the decision using ATRX in these lung carcinoid?
So ATRX has been studied similar to pancreatic carcinoid. So ATRX is basically it helps in DNA replication and helps in telomerase function. So usually it is retained in all the normal cells, and in some tumors like gliomas and pancreatic neuroendocrine tumor, we see a loss of ATRX, which is seen as a nuclear. Normally, it is present in the nucleus, so we see nuclear positivity.
Okay.
So in this case, it was retained, so the ATRX is intact.
Okay, so basically, loss of ATRX is a poor prognostic.
Poor prognostic factor.
Yeah. So this is how the disease responded. The patient was treated with 4 cycles of PRRT, and the liver disease burden has significantly come down. The bone met shows low-grade activity now. Patient was followed up again, and the patient showed stable disease. Now I again come to the surgeon. Now, do we have a role for surgery here, considering that we have somehow brought down the metastatic burden?
So considering that she's a relatively young patient with a good fitness profile, and the fact that she's responded so beautifully to PRRT, with the lung, as I can see on the last scan, being the only site of residual disease, which has remained stable over some time. So we've seen over time that this disease is behaving well. I think we would consider surgery in this patient so as to label her disease free. Again, do we have evidence to say this is going to in any way improve her lifestyle? I don't know, because carcinoids would live long anyway.
Yeah.
But being the only site of disease, I think it merits a consideration.
So basically, apart from the fact that it is the only site, the patient also has symptoms primarily due to the lung mass. So is that also one of the factors which would determine?
One of the chief factors, actually,
Yeah.
because it will improve her quality of life.
Correct. Thanks. Ajay, any adjuvant treatment you would like to offer after surgery in case this patient gets operated? Consider.
So if HPR is showing it's typical or atypical, we don't offer any adjuvant treatment. Only in aggressive tumors, we can offer that.
Okay.
Not indicated.
Point taken. So basically, just not following the routine criteria for operability and inoperability as we do in lung cancers, conventional lung cancers. For carcinoids, if we manage to get down the disease burden, there is still a role for surgery, considering the quality of life, the location of the tumor. This is a good point that we have taken from this particular case. So thank you to all the panelists for taking part in this panel. And I would just like to conclude by saying that the carcinoids do have different ways in which they can be managed, not just the conventional octreotide LAR, which we have been extrapolating from JEPNETs, but PRRT is a good option. Surgery does come in at some point if PRRT works in patients, and targeted therapy is on the horizon. So thank you very much.
Thank you. It was a great panel discussion. So we